people want to understand what the duodenal switch is, it's really two operations. The first part of the operation is a sleeve gastrectomy. The second part of the operation is where we divide the small bowel just past the stomach and we bypass relatively 2/3 of the small bowel. This is like marrying a sleeve gastrectomy with the gastric bypass. So we have some malabsorption from the intestinal bypass and we have some restriction from the sleeve gastrectomy. For the person who has a duodenal switch, you can be expected to lose 80 to 90% of your excess body weight. What that means is that if you're 100 pounds overweight, you would lose 80 out of those 100 pounds. If a person's 200 pounds overweight, you can expect to lose 160 out of those 200 pounds. And that's not only at 1 year, but 5, 10, 15, and 20 years down the road. And the average ending BMI or ending weight is a BMI of 27, which is somewhere around 15 or 20 pounds over your ideal body weight. And for most of our patients, they've not seen that in years and they're very happy with that. The weight loss is rapid initially from month 0 to month 6, and then it tapers off and stays gradual from 6 months out to 18 months. The weight loss from the duodenal switch in the first 2 to 3 years is almost exactly the same as it is for a gastric bypass. However, the difference between the duodenal switch and the gastric bypass is the gastric bypass patients tend to start regaining weight at 13 months from having their surgery, and the duodenal switch patients tend to stay stable for years and years and years. So what happens is the gastric bypass loses weight quickly and starts to regain it, while the duodenal switch loses weight just as rapidly. It just tends not to come back on. One of the other beneficial effects of the duodenal switch is that people don't want to eat carbohydrates after they have a duodenal switch. I don't know why that is. It's one of the perplexing findings of doing the duodenal switch, but it's true. People for years later after the surgery just don't want to eat the refined carbohydrates, the cookies, the breads, the pastas that they did before the operation. We don't know why that is. We just know it results in better long-term success for our patients. The duodenal switch is twice as good as any other operation for the cure of diabetes. Its long-term diabetes resolution rates are 90% at 5, 10, 15, and 20 years, as opposed to gastric bypass around 60% and the sleeve gastrectomy around 45%. What that means to patients is that their hemoglobin A1C is normal and they don't have to take any medications, whether that's insulin or oral medications. That means totally free from medications and having normal blood sugars whenever they're checked. For patients with high blood pressure or sleep apnea, what we see after the duodenal switch is 80 to 90% of those medical problems go away. Another interesting finding with the duodenal switch is that patients who have coronary artery disease or high blood cholesterol, that it's eliminated almost instantly with the surgery, and their heart attack and stroke risks fall dramatically. The first one that people experience is the possibility of diarrhea. We've been able to reduce that to less than 1% in our practice, but it is still real and we have ways that we can deal with that. But the biggest one that people have to worry about in terms of post-operative problems with the duodenal switch is nutritional supplementation. Everyone needs to be on a vitamin regimen following the surgery, and if they're not willing or able to do that, they shouldn't have a duodenal switch done. It's so important because if you don't do it, you will develop vitamin deficiencies, and this is vitally important both in the short and long term with everyone who has this operation. For a person who's going to have a duodenal switch done by us, we typically do the surgeries on Monday and Tuesday, and the person who has the surgery on Monday, 90% of the time goes home on Tuesday. When they go home, we expect them to be on a full liquid diet. That means any liquid that you can drink, that you can put in a blender, you can have, and that's for the first 2 weeks. For the 2 weeks after that, we expect that patients will be on a soft food diet. That means any food that's easy to chew up and won't result in big chunks going down. And so at the end of your first month following surgery, you can eat normally again. And you'll be able to introduce foods one at a time as you go through the days and weeks following. This surgery, the loop duodenal switch, was developed out of a group in Spain. We read the papers of those surgeons in Spain and we realized it offered a lot of solutions to the complications experienced by both the gastric bypass and the traditional duodenal switch. We began doing this with a friend of mine, a surgeon in New York named Mitchell Roslin. We started this together and went through the learning curve together and developed the techniques that are now used around the world. It's been a revolution both for us in our practice and for our patients, and it's been a revolution around the world in seeing people adopt this and see the amazing results that they have with it. One of the biggest differences between our program here at the Bariatric Medicine Institute and the other programs in the Intermountain West is that we are actively looking at our data every single day. We're big researchers, and because we're big researchers, that means that in order to publish the papers and do the presentations that we give all over the world, we have to intimately know the details of our data. For instance, this led us to conclude that the sleeve gastrectomy doesn't work in all our patients. It led us to conclude better ways to treat the complications that happen to patients. And it's led us develop new innovative techniques with the duodenal switch, all because we're actively seeking the answers to questions that most people don't answer. But we're the only people in the entire Intermountain West, and that includes every university that you know of, that have an entire research department with full-time staff. And we're able to do that because of our commitment to our patients. There's been a great sea change in the bariatric world, switching from the gastric bypass to the duodenal switch and switching from the sleeve gastrectomy to the duodenal switch. Over 80% of patients, if your BMI is over 50 or if you're diabetes, you're not going to lose enough weight to be effective. And hence, those patients are good duodenal switch patients. And the biggest thing that we've seen in switching from the gastric bypass to the duodenal switch is the rate of long-term complications goes from 25% to 6%. So that's a 4-fold decrease in complication rates when you stop doing gastric bypasses and you start doing duodenal switches. And for those patients who only can have a duodenal switch, the diabetics and the people with BMI over 50, this has been a wonderful sea change. In general, your surgeon should take into consideration what your preoperative weight is and what your preoperative medical problems are before deciding with you what surgery would be appropriate for you. We recommend the duodenal switch for any patient who has a BMI over 50 or who has diabetes. Typically, in my office, I will tell patients if their BMI is less than 45 and they don't have diabetes, I'll recommend that they have a sleeve gastrectomy. If they have a BMI over 50 or have diabetes, I'll recommend a duodenal switch. In the end, the choice is always the patient's. However, we found that if you have one of those problems, meaning your BMI is over 50 or if you have diabetes, 80% of the time the sleeve gastrectomy will not be enough surgery for you, and you'll end up having to have a duodenal switch done in the end anyway. As always, good luck on your weight loss journey.